All right, so today we're going to talk about something that's absolutely fundamental to your career in medicine. How do we get the diagnosis right every single time? We're diving into a really important guideline from the College of American Pathologists all about cutting down on interpretive errors. And this is aimed squarely at you, the people who are right on the front lines learning this craft.
Think about it. You're spending all these years training your eyes and your brain to recognize patterns, to make these incredibly critical diagnostic calls. But here's a challenge you're absolutely going to face. Even the most seasoned experts can look at the very same slide and come to different conclusions. So, how often does this actually happen? And what does it really mean for patient safety? Let's just look at the cold, hard data. When the CAP expert panel went through over 100 different studies, they found that the median rate of diagnostic disagreement was a pretty staggering 18.3%. Let that sink in. That means in almost 1 out of every 5 cases that gets a second look, another pathologist has a different take. This is not some rare thing. But okay, let's drill down to the number that really matters for the person on the other end of that report. Within that larger group, the median rate for a major discrepancy was 5.9%. And these are the big ones, the disagreements that could actually change a patient's treatment plan, their therapy, or their whole prognosis. Now, I know seeing numbers like that can feel a little intimidating, but the one thing this guideline makes crystal clear is that this is not about pointing fingers or blaming individual pathologists. It's about recognizing that this is a tough field with inherent challenges. The real goal is to build smarter, more robust systems to support everyone, improve teamwork, and catch potential errors before they can ever affect a patient. So you might be asking, where do these disagreements even come from? Well, it all starts with understanding the unique nature of pathology itself. You see, unlike a lot of other lab tests that spit out a clean number, a pathologic diagnosis has a huge element of human interpretation baked right in. This all happens in what's called the analytic phase. That's the moment where a pathologist's knowledge, all their experience, and their professional judgment come together as they look through that microscope. It's this human analytic step that makes the whole process way more subjective than, say, your standard clinical lab test. So, getting to the right diagnosis is this big puzzle with a lot of pieces. Of course, it relies on a pathologist expertise, but it's also about checking the clinical story, using standard criteria, and sometimes running extra tests. But I want you to look at that last point, secondary review of cases. It's right there on the list. It's considered an essential piece of the puzzle from the very start, not just some afterthought. And that brings us right to the core solution that the CAP guideline puts forward. If we accept that a certain level of subjectivity and disagreement is just part of the process, then the absolute best way to guarantee quality and safety is to have a systematic, planned-out approach to case review. The big shift in thinking here is moving from reactive to proactive. This isn't just about catching mistakes after they've already happened. The guideline frames this as a forward-thinking strategy, a quality assurance system that's designed to stop errors from ever getting into that final report that a clinical team is going to use to make life-changing decisions. Now, when we talk about doing a review, timing is absolutely everything. A prospective review, that happens before the final report is signed out. This is the gold standard, right? It catches any potential issues before treatment decisions are made. Then you have retrospective review, which happens after the case is closed. It's still super valuable for learning and education, but it can lead to amended reports, which can cause confusion and extra work for everyone. So to make this whole system a reality, the expert panel laid out a really clear 5-step framework. We're going to walk through these because, honestly, this is the system you're going to be working in and helping to improve for your entire career. Think of it like a continuous cycle, a loop. It all starts with developing formal procedures. Then you actually do the reviews in a timely way. After that, you document everything, you monitor the results, and you use all that data to get better and improve agreement across the whole team. So let's see what each of these really means. First up, every practice has to have a formal plan. This can't be random or ad hoc. It means sitting down and deciding which cases get reviewed. Maybe it's a certain percentage, or maybe it's specific tricky diagnoses or all new cancers, and you make that a standard, predictable part of the workflow. Second, we're back to timing. It is so critical. The guideline really pushes for getting that second set of eyes on a case before it's finalized. And this is about so much more than just avoiding paperwork. It's about making sure the patient starts on the right treatment path from day one. No delays, no backtracking. Third, you got to make it official. These procedures need to be written down, clear as day, right in the lab's quality assurance plan. And what's really important is that this isn't a one-size-fits-all kind of deal. The plan has to be tailored to fit the specific needs, the resources, and the type of cases each particular practice handles. Okay, step 4 is where you become a bit of a data detective. It's not enough to just do the reviews. You have to track what happens. You're looking for patterns. Are there certain kinds of cases that always seem to spark a debate? By monitoring the results, a department can spot these trends and pinpoint exactly where the team needs to focus to get better. And that leads perfectly into the final step, taking action. If you find out that, say, there's poor agreement on how to grade a specific tumor, the department has to do something about it. That could mean getting everyone together for a consensus conference to hash out the criteria, or using calibration slides to make sure everyone's eye is trained to see the same thing. It's a true feedback loop for getting better and better. So let's bring it back to you. As a trainee, why should you care so much about all this? Because this framework isn't just some set of rules handed down from on high. It is literally the blueprint for the professional world you're about to enter, and believe me, you have a vital role to play in it.
I mean, this quote from the guideline really says it all. Case reviews are not a test to see if you messed up. They are a tool for learning. It's your chance to see how your colleagues and mentors tackle a tough case, to build relationships, and to constantly sharpen your own skills in a safe, supportive setting.
At the end of the day, this entire system is designed to help you succeed. When you embrace systematic review, you're doing more than just protecting patients. You are actively taking part in a culture of collaborative learning that's going to build your confidence and make you a sharper, more reliable physician for your whole career. So these guidelines, they provide the structure, the skeleton, but the actual culture of quality, of collaboration, and of always wanting to improve, that is built by the people inside that system. As you finish your training and move into practice, the real question isn't just what you'll do, but what kind of culture will you help build?